of cough for 7 to 8 days where the cough is productive and he is having fever for 3 days and within difficulty for like 3 to 4 days. So you take the history and do the examination how you will do proceed. So just give a brief outline.
So hello, I am Bcon Sarkar, a first year MBBS student. So I'll be doing a general examination of your respiratory system. So may I have your consent of doing all the examination needed? So please lie down.
First you start general examination without asking him what his problem is, how long he is having the problem. You just need to examine the patient first. You are very eager. You have to first again.
May I know what complaints are you suffering with?
Not respiratory problem, just like a layman. Just how a normal person would tell. Normal person comes to you and will tell you that I have a respiratory problem. He doesn't know about respiration. He will tell I am coughing, I am having, just in English only, but in plain English, not in medical terms. Not like I am having problem in respiratory system, not like I am having problem in respiratory system like this. You just tell him that I am having cough for these days. He will ask that if it is productive or not, if it is dry cough. Like this, you tell your symptoms like a normal person. Don't tell like respiratory system and all. Ask.
Cough, body pain, and sometimes blood coming from the cough, and breathing problem sometimes.
So what is your age?
Age is 20.
What is your occupation? Is there anyone in your family who is having the same problem?
Yes, some of my parents and some of my grandfathers.
Okay. Have you undergone any surgeries in your past?
No.
Anyone from your family? Anyone from your family?
Yes,
Close family? So now I'll be examining you. So may I have your consent?
Only this much. I will not ask the duration of the cough. You didn't have to ask about the duration of the cough, about the duration of the blood with the cough, along with the cough. These things are more important than surgery, na?
Okay.
This patient is coming with cough, you are not asking about cough, you are asking about his grandfather's cough. And what is the meaning?
Okay. So how long are you suffering with cough?
Cough from 1 to 2 months.
Is there mucus present with the cough?
Small.
No. So it's a wet cough, na?
Yeah.
Okay. So is there blood coming out?
Sometimes.
Okay. Sure. So now I'll be starting.
Okay, proceed with the examination.
Okay. Please line up.
Which system you will be examining? Which system are you going to examine in this patient?
Respiratory system, sir.
तो इधर कोई तो कौन लगे?
So first I'll be
Key.
consent analysis.
Concern नहीं है सिवा dress को ले लो. तुम्हें dress को बाहर supposed to touch his dress.
May
He
you
will open his dress himself or any attendant will open.
Okay, sir.
You are never supposed to open the dress of the patient.
Open
अच्छा अटकुल दे दो ना हमने को.
Okay, sir. First I'll be doing the inspection, sir.
What will be seeing in inspection?
I'll check the position of trachea, sir, and then
Firstly, I will check the position of trachea, not about the chest.
I'll see the chest, like the rhythm of breathing, the shape of chest, size of chest, whether it is barrel shaped or pigeon shaped. I'll be checking how deep, the depth of the chest.
You in the exam you don't need to order about this that if it is barrel shaped or pigeon shaped. You just simply tell that I will check the size and shape of the chest.
Okay.
Then the examiner himself will ask that what is the normal shape, what is barrel chest. If you are himself giving these hints that I will check for barrel chest, then in the next question will be what are the other different types of abdominal shapes of the chest. Then you will be not having any answer.
Okay, sir.
So you shouldn't give clues like this.
Okay.
You just go plainly that I will check the shape and size of the chest, then other things what I will check in inspection on these things. Don't need to utter this complex terms.
Okay, sir. I'll be checking the rhythm of breathing, rhythm of respiration, rate of respiration. Then checking the depth of respiration.
Depth, all these things. This is not called depth. And that is the expansion of the chest. It is called expansion of the chest, not about depth of respiration.
Okay,
It is called the expansion of chest.
expansion of chest.
Expansion you will not check in inspection. In inspection you cannot check expansion. In palpation only you can check expansion.
Yes.
You will measure it only, then you can know how much it is expanding. By seeing you can know how much it is expanding.
No, sir.
Rate rhythm, and then shape of the chest. You will check for any scar marks. You will check for any visible lumps or visible swelling. You will check for the
Apical
position
impulse.
of the trachea. Then any discoloration, any rashes in the skin of the chest, any the apical impulse if it is visible or not. These things you have to tell. You should not tell the abnormal things first. You just check go with the normal way.
Okay, sir. Then with this inspection will be done.
No, these things I only told you, na. You tell, ask him. How you see? You tell me what are you going to see?
I'm going.
Serialize.
Okay, I'm going to check the shape and size of the chest, and the rate of respiration, the rhythm of respiration. Then I'll be checking for any scars and in the chest region or any discoloration in the chest region. Then I'll even check the position of trachea, and I'll even check for.
How will you check the position of trachea? What will be the changes if the trachea is shifted to any side? Didn't sir tell you that the sternocleidomastoid will bulge? There will be bulging of the sternocleidomastoid muscle. Wherever is the position of the trachea is deviating, the trachea will push the sternocleidomastoid muscle. So that will bulge. That is called trail sign. You don't need to remember the trail sign name. Just remember that the sternocleidomastoid muscle will bulge. Simply you remember because the trachea will be pushing it. It will be bulged. No, it will be going inside it. So it will bulge. This is how you can see the deviation of the trachea in inspection.
Okay, sir.
Then you have to see the apical impulse.
Yeah.
Then you have to see the type of breathing. It is abdominothoracic or thoracoabdominal. This thing you missed.
Okay, sir.
Then another thing was there. No, I think this we have covered. Yes, okay, these things only. I think something I missed. Okay, you carry on. Then after
This
that.
my inspection will be done. Then I will going into the palpation.
Yeah, one thing is there. You have to check the accessory muscles of respiration. Sir has told you. There are accessory muscles of respiration. Accessory muscles means the serratus anteriorus, then scalene, then latissimus dorsi. Yeah, there are many muscles. There are some muscles for expiration, some muscles for inspiration. These are the extra muscles which the body will be using if the body is not getting enough oxygen. So it has to give extra effort to get oxygen. So these are these muscles. Okay, then carry on.
After this,
Inspection is completed. After that, what will do?
palpation, sir. First I'll palpate his trachea, sir. Can you please?
You tell the patient to sit or to lie down?
No.
Huh? You will tell the patient to sit or to lie down?
Good night.
To lie down.
To sit, sir.
If he is lying down, then his trachea is also going on back side. How can you trace it? If he is bending forward, then only trachea will be bending forward. It will be easier for you to trace. Simple, normal things. How will you trace the trachea?
I'll be pointing my pointing finger.
Pointing
Finger, index finger, and
I can point in this finger also. I can point with this
index
finger.
finger and then my middle finger. I'll be
The middle finger? Sorry, middle finger.
sorry, sir. My ring finger. And I'll
Where will you put your finger?
be in the clavicular end, sir.
Clavicular end. Yes, this is also clavicular end.
Sternoclavicular end, sir. Sternal end, sir.
Sternoclavicular end, sternal end on the clavicle. Then you will palpate throughout the whole of the trachea till the sternal notch. Whole of the trachea till the sternal notch.
Okay, sir.
If there is any deviation, you will find out.
Okay, sir.
So this is about the trachea. Then what are the things you will be seeing in palpation?
After trachea, sir. Trachea done. Trachea done.
You will check for the movement of respiration. Any that thing, you know.
Expansion of chest. Expansion of chest. I'll be even checking the apex beats, sir.
First you show the expansion, then you go to the exhibit.
Okay, sir.
Show the expansion. How will you go? How will you check? Tell me. How will you check?
I'll be having the check with the strips.
With the
Measuring tape, sir.
one thing is that
In the nipple
where will
lines.
you
Nipple
in the
lines.
back side in the T7 vertebra.
Yes, sir.
So we'll be checking the expansions in different ways like full inspiration and full expiration, and then we will measure the difference. What is the normal difference? 4 to 7 centimeter. Then there goes with the measuring tape. Then with your hands you will also see see if any symmetry is there in the expansion. How will you check? Which regions?
In the 10th ribs.
And he has to, if he is lying down, how will he, again and again you are doing the same mistake.
Let's see. Take deep breath. Exhale. Take deep breath.
You are fixing your thumbs, then how will your thumbs move? You are supposed to keep these parts fixed, and you are supposed to keep your thumbs free, so that when the patient is breathing, your thumbs are moving. If thumbs are free to move,
Okay, sir.
then only you can assess. You are keeping your thumbs fixed, and how will you assess?
Okay, sir. Take deep breath.
Okay, you have to keep your hands like this. Then you have to keep your thumbs free so that they are able to move. Yeah, move loose and free. So whenever the person is breathing, thumbs will move like this. Not like this much, but like this.
Yes.
It will move like this. So if some thumb, if this thumb is getting upwards, this thumb is lower, then you will see that okay, there is some pathology. This lung, part of the lung is not rising. So after that, what other places you will be looking for in this expansion of the chest? Other methods are also there, no? Other places also there.
Infrascapular regions.
That is another part. Another 3 things are there.
One is infrascapular, 10th rib.
Why we are checking the 10th rib? Let others tell. Where you tell? You two are discussing, no? You tell me. Come forward. Why you are using the 10th rib? You could have come forward na, and see what he is doing. But rather you decided that you will discuss by yourself and you will answer everything. Okay, then you will answer. What is the use of the 10th rib? Why are you using the fingers at the 10th rib only and not on the feet, the 6th rib? Why? Hello, answer. Because the 10th rib is the last true rib. After that, there are the floating ribs. And this rib is having the largest diameter, and the expansion of the lung is the most in this part. So the more expansion we check, the more expansion we can know the difference. So that's why we are taking the 10th rib. And to discuss here. Come forward and see. Okay, then other things we can do. One thing is, we will tell the patient to turn the back towards us, and turn this side. Then this is here is the place where the apex of the lung is there. The apex is near this much. So here is the shoulder blades, the shoulders. We will keep our hands like this, and we will fix not fix like in a similar way. We will keep our thumbs loose and free. So and we will tell the patient to breathe. You breathe strongly. Heavily. You breathe. Yeah. So you can see that whenever he is breathing, my fingers are getting stretched. They are moving. So if this finger is moving away, this finger is at the same place. So I will know that there is some symmetrical difference in the breathing. So that is the third part. One is like this, one is the intrascapular region, and one is what you showed right now. So these are the things. How will you know the difference in the expansion of the lungs?
Okay.
So one thing you told about trachea, position of trachea, then expansion of the lung. And what are the other things?
Lymph nodes.
Yeah, lymph nodes you can see. And then some basic thing what I will see.
Epics.
No. Temperature. Temperature. And what is the most basic thing in our palpation. In palpation, we will just palpate smoothly like this, and we will look for any lumps, any swelling, any tenderness, any lymph nodes are there, any broken ribs are there. So you will palpate like this gently, and you can see, you can find out if there is any deformity. In all the areas, you have to palpate this mammary area, inframammary area, then axillary area, infraaxillary area, then intrascapular, scapular, suprascapular, infrascapular. All these areas you have to palpate like this. Then what are the other things left? In palpation only. There are more things.
Apex
apex
lymph
is there. Vocal fremitus. That thing you missed, na?
Yes.
First, so vocal fremitus I will show. Till now you are doing good. At least with respect to other classes, what others did, you are doing good. You just try.
So I'll
Just to know what
fixing my ulnar answer in the intercostal spacer.
Look, what you are telling now, it has to be crystal clear in your head also, and the examiner has to listen to this also. Even then, if you are not able to do this, but you are able to explain this, at least he will give you some mark. But if you are fumbling like this, if your voice is not clear, then the examiner will know that you are not able to do also and don't know also. Then obviously you will not be getting a mark. And just keep on doing.
Okay, sir.
First year it can be overwhelming for you. It can be a little difficult, but you at least know what you have to do.
Okay.
So,
Yes, please say 1, 1, 1.
what you will do first? You have to explain.
Sir, I'll be placing my ulnar end of my hands in
Ulnar border.
border of the hands between his intercostal spaces, and I'll asking him to say 1, 1, 1 to feel the vibration, and I'll comparing the vibrations in both the sides, sir.
Sure.
1, 1, 1.
Not like this. You have to tell like 1, 1, 1 in one go.
Yeah.
Like not like 1, 1, 1. Like this 1, 1, 1 or
1,
9, 9, 9. Whatever.
1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1. 1, 1, 1.
You don't need to do like this. You just keep it simply. Not like this. What are you doing?
1, 1, 1. 1, 1, 1. 1, 1, 1.
Okay,
System.
okay. In the back also, in the axillary region also, you have to
Yes.
perform it. In the back, you show me how you will do.
Confess.
What you will tell the patient first if you are examining the back?
Yeah, please hold your.
Show him.
Please hold your back. Do like this. Yeah.
Because the person who will be coming, like suppose if any patient is giving to you during the exam, maybe some patient will be given some. You cannot tell the patient to process. He will not understand. You have to show him like this, do like this. Then the patient will understand. And why you are doing this?
To it's the back better.
Yeah, for expansion of the
back region.
Ask him to do.
1, 1, 1.
Okay, this is the ductal vocal fremitus. Similarly, you will do.
Yes.
And you show me the apex bit. You have already told.
Apex bit, okay.
These points you just keep on revising. Like 1 or 2 days later, 1 or 3 days later, you just see the points. I've shown you some slides actually. Not slide. I have made in MS Word some things. You can go through it once in 3 days, 4 days. At least you will remember. If you see them regularly, you will remember. Then apex bit. Show me how will you show.
Can you please slide down?
Yeah, it was.
Please. I'll do above.
No need to. You just show.
Okay.
For
So
rapid
I'll
use.
feel his sulcus.
Huh?
Sulcus. I'll feel his sulcus.
Sulcus, which sulcus?
Below this I'll be sulcus. Then I will be going
Laterally.
laterally, sir.
What will you feel?
Second rib, sir. Then
Then
below this I'll be second intercostal space, sir. I'll be going this fifth intercostal space, sir.
where it is supposed to be?
Near the nipple region, sir. And
And what is the normal location of the apex bit? 1.2. It is actually 1.2 centimeter around the
Medial side.
medial.
from the mid clavicular.
Imaginary line from the
1.2
mid.
centimeter medial to the mid clavicular line. So
Then
it is around the just an average around this it is present. This is how will you feel? Directly you will put your finger.
no, sir.
Then
Then
How
I'll
will
do
you-
this. Take deep
tell
breath.
me. Take a deep breath, please.
No, sir.
What is the relation of deep breath with the apex bit?
I'll feel vibration, sir. Then the place where the
Firstly, you will put your ulnar border. If the apex bit is here, how will you feel the vibration?
put my
First, you will put your palm.
palm, sir.
Where you will feel the maximum vibration, then you will trace that part, then you will put the ulnar border. And then you will put your finger. Largest space, then smallest.
Okay, sir.
Like this.
Okay, sir.
Then you felt the part of the maximum vibration. Then you will put your thumb or your finger. Thumb on one finger only. Then you have to locate it, na?
Okay, sir.
Then what is the use? If you are feeling it in this much area, then how will you diagnose that
Yes.
it is shifted or not?
Yes.
You have to pinpoint that it has shifted around 1 centimeter only. Then also it is some deformity.
Yes.
Some abnormalities there.
Yes.
So you have to locate that. If you are tracing it in an area, then
Yes.
what is the use of tracing the apex bit?
Yes.
Then this is the apex bit. Anything left in palpation? Then after palpation, what you will do?
Percussion, sir.
So what you will do in percussion? You just tell me first. Tell me.
I'll be taking my dominant hand, sir. And then
What is this called? What is this finger called? What is this finger called?
middle fingers.
No means what, on which finger you are tapping. What is the term called? This one is flexor or this one is fleximeter? Yeah. This one is flexor, this one is the fleximeter.
Sir,
This one is the fleximeter, this one is the flexor.
fleximeter, flexors.
Flexor. How will you percuss? First you explain, then you do. How will you percuss? What are the spaces you will percuss?
Sir, in the memory area between
First you will go to the memory area. There are any other regions?
sir, infrascapular, intrascapular, suprascapular.
Scapula. You leave the scapula. First you tell the anterior part of the chest. Only memory area is present in the chest. There is no other area.
Sir, below clavicular, infraclavicular region.
There is no supraclavicular area.
Supraclavicular, infraclavicular.
Then I am keeping on telling you again and again. Then you are repeating it. What is this? You have to first see the supraclavicular region. Then supraclavicular, then clavicular. How will you? You show me the palpation of the supraclavicular region. Percussion. Sorry, percussion of the supraclavicular region. Do you think you will get any sound if you are doing this? Here. Do you think you will get any sound? Like this you have to do. Then you will get any sound. You have to give a strong force. Then only you will feel the sound. Okay, then supraclavicular. Then clavicular you palpate. You percuss. Wrong. In any bony part, you will not use this finger. You will only use the flexor to percuss. Directly in the bone you will percuss. And what will be the normal sound in percussion of the chest?
Normal sound of the chest, it will be, sir, resonating sounds.
Okay. Percuss. No, you are not even producing any sound. Like this. Like this. You are keeping your hand stiff. That is the problem. You have to keep this loose. Then you have to percuss like this. You are doing like this, not like. The movement should be here, not like here, not like here. It should be free. Yeah. This thing has to be free. Like this. Then, what are the parts?
Then infraclavicular region.
Sure.
And so the memory region between the intercostal spaces.
What is the memory region? What is the location of the memory region? From which rib to which rib? Anyone can tell.
It's up to the fourth.
Fourth rib. What told you? Is it written somewhere that it is up to fourth rib? Second to sixth rib.
Second to sixth.
Second to sixth rib is the memory region. Below that is the inframemory region. No. You have to check the intercostal spaces, not the ribs. Okay. Similarly, you have to do the axillary region, this much, then the infraxillary region, then the suprascapular, then scapular, intrascapular,
And infrascapular.
infrascapular. एक्सरेट बहुत ज़्यादा हो रहा है मेरे ऊपर कर रहा है फिर then this is the percussion. What are the abnormal sounds in percussion in of the chest? Everyone's turn will come, na? No need to worry. Then I will ask you.
Wheezing sounds.
In percussion, you will get wheezing sound.
Sorry, sir, not percussion sound. And
Dull sound, hyper resonant sound. Normal, what is abnormal in abdomen? The same thing is abnormal here. So this is about percussion. Any other thing left in percussion? Yeah, where will you find the liver dullness?
from the 6th intercostal space in the right side. With head dullness, liver dullness.
Okay, is there any significance of this liver dullness in this respiratory examination? For a question for all, is there any significance of this liver dullness in the respiratory system examination?
Yes, dullness is not there, it gets flowed away.
Yeah, if like the liver is shifted downwards, if you are getting it in the like 9th intercostal space or even lower, or if you are not even getting in the intercostal spaces, then that might indicate that due to some reason the lung has expanded, maybe due to pleural effusion, due to collection of anything, the lung size is expanded, due to which it has pushed the liver below downwards. That's why the liver dullness is missing. Or there might be some abnormality. If it is upwards, then there might be another abnormality is there. So this is the important things. Then any other thing I'm missing in this percussion? Okay, take percussion is gone. Yeah, what is the use of this apex beat of the apex beat which are measuring in palpation? Apex beat, what is the importance?
Whether it is not fast.
No, not
Should
so fast.
activities or we find the maximum amount of speed?
We know that.
Whether we can feel that it's beating.
Yeah, whether you can feel it in its place or not, whether it's shifted or not. If like some like in right-sided pleural effusion, if there is right-sided pleural effusion, the lung will be growing bigger in size. So it will push the heart. Heart is here in between this lung and this lung, and nearly shifted to the left, but in between both lungs only. So if if this right lung is expanding too much, it will push the heart away. So suppose it is we are supposed to get it in the 5th intercostal space near the nipple, but now we are getting it here. So there is shifting. Or suppose we are not even getting the this apex beat, it is shifted somewhere in the middle. The heart is shifted somewhere in the middle. So that is an important thing. So by this you can measure that why the apex beat has shifted or not. That is another thing. Then we'll be checking. You first tell me what things you'll be checking in observation. Yeah, we will be using the trachea, but for what purpose?
For the sounds, the breathing sounds.
Which sound?
Should be hollow sounds.
Which sound?
Hollow sounds.
Not hollow sound. It is a name, na. Its character is hollow, but it has a name. There are two types of sounds in the lung or in the trachea, whatever. There are two types of sounds.
Vascular sound should be in the chest.
Which sound?
Vascular sounds should be in the lungs.
Vesicular breath sound.
sounds.
And another is bronchial breath sound. Bronchial
sound.
bronchial breath sound. So we will listen to the bronchial breath sound in this trachea up to this sternal notch. This part, only in this part, you can feel you can listen to the bronchial sound. So you will listen to this first. Which sound is more louder? Bronchial or the vesicular?
Bronchial. It's vesicular sounds.
Bronchial. Check. Yeah. This one is more louder. This is mild sound, normal sound. Everything apart from this part, which sound you are listening, is vesicular breath sound. It should be vesicular breath sound, and this part only is the bronchial breath sound. You will listen to this.
Breathe.
What sound you are listening to? Which
Vascular
sound?
sound.
Vesicular, not vascular.
Vesicular sound.
Here also you can listen. Then in the back, in the scapula, everywhere you have to listen, because sometimes there might be pneumonia in this place, So you have to listen carefully everywhere. Up to this much only. This is bronchial. up to this notch, up to this sternal notch, this is bronchial. Apart from this, everything else is vesicular. And what are the abnormal sounds? Can you name some abnormal sounds of the chest respiratory system?
Wheezing sounds.
How will you sound like? How will you differentiate wheezing sound? Just whatever you know, just you tell me. No need to be specific. Just how will you differentiate these wheezing sound? Crackles, crepitations, then dual rap. Okay, fine.